Welcome to this video on chronic disorders of the pediatric respiratory system. The learning objectives are to understand major chronic respiratory diseases, explain pathophysiological mechanisms, recognize clinical features, apply diagnostic approaches, and outline detailed management. Cystic fibrosis, or CF, is an autosomal recessive disorder. It is relatively common in Europeans and rare in Asia. The pathophysiology involves the cystic fibrosis transmembrane conductance regulator, or CFTR, gene on chromosome 7. Mutations in this gene lead to abnormal or absent CFTR protein, resulting in thick, sticky mucus in the lungs and pancreas. The core pathophysiology of CF involves decreased chloride secretion and increased sodium and water absorption into the cell. This results in reduced water content in the lumen and, consequently, thick mucus. This diagram illustrates the difference between a healthy apical membrane and a cystic fibrosis apical membrane, showing the impaired chloride secretion and thick, sticky mucus in CF. There are 6 CFTR mutation classes. Class 1, present in 10% of patients, results in failure to manufacture functional CFTR protein. Class 2, seen in 70 to 90% of cases, involves CFTR protein misfolding and degradation before reaching the cell surface. Classes 3 through VI include various other defects. Clinical features of cystic fibrosis include meconium ileus at birth, chronic cough, recurrent infections, and poor growth. In cystic fibrosis lung disease, thick mucus traps bacteria, attracting neutrophils. Dying neutrophils release DNA into the mucus, which acts like a web, cross-linking with the mucus and making it very sticky. Recurrent infections with Staphylococcus aureus in early childhood, followed by chronic colonization with Pseudomonas aeruginosa, are common. This leads to chronic inflammation, bronchiectasis, an obstructive type of lung disease, and clubbing. Cystic fibrosis also affects the GI tract and pancreas, causing pancreatic insufficiency due to exocrine dysfunction. Thick mucus plugs the pancreatic ducts, causing enzymes to accumulate inside cells, leading to autodigestion of pancreatic tissue. Over time, healthy tissue is replaced by cysts and scar tissue, hence the name cystic fibrosis. Clinical features from GI and pancreas disease include the inability to secrete digestive enzymes, which prevents the breakdown of fats and proteins. This results in steatorrhea, or foul-smelling, oily stools, and malnutrition leading to failure to thrive. Cystic fibrosis is a multi-organ genetic disorder with various clinical features affecting the respiratory, digestive, genitourinary, and other systemic function. Diagnosis of cystic fibrosis includes newborn screening to check for immunoreactive trypsinogen. Confirmatory tests are the sweat test, where chloride levels are 60 mmol/L or higher, and genetic testing for CFTR mutations. Newborn screening uses blood spots to check for increased immunoreactive trypsinogen. This enzyme leaks into the blood because it cannot be secreted into the intestine. This is followed by genetic testing of the same blood sample and the sweat test as the gold standard for confirmation. The sweat test is crucial for diagnosis. In normal subjects, chloride and sodium move into the sweat duct, resulting in low salt sweat. In cystic fibrosis, however, chloride and sodium stay out, leading to salty sweat. Management of cystic fibrosis focuses on airway clearance through chest physiotherapy, oscillatory devices, and daily therapy to help loosen and remove the thick mucus. Inhaled therapies are used to manage symptoms. These include bronchodilators to reverse airway hyperresponsiveness, hypertonic saline to hydrate mucus, Dornase alpha to cut neutrophil DNA, and antibiotics to break down bacterial biofilms. Infection control involves regular cultures, inhaled antibiotics for chronic infections, and intravenous antibiotics for exacerbations. Nutritional management requires a high-calorie diet, taking pancreatic enzymes with meals to aid digestion, and fat-soluble vitamin replacement for vitamins A, D, E, and K. CFTR modulators, available since 2019, are groundbreaking treatments that bypass genetic defects. They are specifically for classes 2 through VI mutations, turning an untreatable cellular error into a manageable condition. CFTR modulators have fixed the cellular error in 90% of CF patients, but the reality is high costs. The hope for the future is generic production at a lower cost. Now let's move on to primary ciliary dyskinesia, or PCD. PCD is an autosomal recessive disorder that affects the structure or function of modal cilia. Cilia are microscopic, hair-like projections that beat in a coordinated manner. PCD is a rare, autosomal recessive disorder with a prevalence of 1 in 10,000 to 20,000. It is often underdiagnosed, and about 50% of those affected have laterality defects. In PCD, cilia are either stationary or dyskinetic, meaning they have uncoordinated beating. This leads to stagnant mucus, chronic infection, and eventually bronchiectasis. Early clues for PCD include neonatal respiratory distress in term infants without clear risk factors, and chronic, daily, persistent wet cough starting in early infancy. Other clinical features include chronic rhinosinusitis and otitis media, which can lead to hearing loss. Laterality defects like situs inversus are seen in about 50% of cases, leading to Cardiganer syndrome. Situs inversus occurs because motile cilia at the embryonic node determine left-right body orientation during early embryogenesis. In PCD, these cilia do not function properly, leading to a random orientation. Diagnosis of PCD has no single gold standard test. It involves clinical history and CXR, nasal nitric oxide testing, ciliary biopsy with electron microscopy, and genetic testing. One key diagnostic feature for PCD is a decrease in nasal nitric oxide, a compound produced by ciliated epithelium. Normal ciliated function generates high levels of nitric oxide. Therefore, low levels are highly suggestive of PCD. PCD management includes daily, lifelong airway clearance therapies such as chest physiotherapy and the use of PEP or oscillatory devices. Adjunct therapies like hypertonic saline are also used to improve clearance. Next, we will cover bronchiectasis and chronic suppurative lung disease, or CSLD. Chronic suppurative lung disease is a clinical diagnosis characterized by a chronic wet cough lasting over 4 weeks that recurs even after antibiotic treatment. Bronchiectasis is the pathological and radiological end-stage diagnosis involving the permanent, abnormal dilation of the bronchi. The gold standard test for diagnosis is high-resolution CT, or HRCT, of the chest. A key finding is the signet ring sign, where the bronchus internal diameter is larger than the accompanying pulmonary artery. Digital clubbing is a clinical sign indicating chronic hypoxia and suppuration. Differential diagnoses for bronchiectasis and CSLD include post-infectious damage, genetic causes like cystic fibrosis and PCD, immune deficiencies, and aspiration from conditions like GORD or swallowing dysfunction. The goal of management is to break the vicious cycle of mucus stasis, infection, inflammation, and airway damage. Chest physiotherapy, utilizing techniques like active cycle of breathing techniques and PEP devices, is the most important daily intervention. Pharmacotherapy for exacerbations is guided by sputum cultures, often requiring aggressive 14-day courses of antibiotics. Long-term prophylaxis, such as azithromycin 3 times a week, is used for its anti-inflammatory properties, especially if a patient experiences more than 3 exacerbations per year. Hypertonic saline is also used to help clear mucus. Finally, we will discuss pediatric interstitial lung disease, known as CHILD. CHILD is a rare, heterogeneous group of chronic lung diseases in children, characterized by diffuse lung involvement and impaired gas exchange, affecting the alveoli, interstitium, small airways, and pulmonary vasculature. The term interstitial can be misleading, as CHILD involves more than just the lung interstitium. It also affects alveolar development, surfactant homeostasis, the capillary network, and the small airways. Consider CHILD if 3 or more signs are present: persistent tachypnea, fine inspiratory crackles, hypoxemia, chronic cough, failure to thrive, digital clubbing in older children, or abnormal chest imaging. Key investigations for diagnosis include HRCT of the chest as the cornerstone, age-appropriate lung function tests, genetic testing, bronchoscopy, and, rarely, a lung biopsy as a last resort. Management involves treating the underlying cause, if identified, and supportive care. This includes oxygen, nutrition, vaccinations, and anti-inflammatory therapy in selected cases. We also manage complications such as pulmonary hypertension and infections, with long-term follow-up in specialist centers.